Thank you, Dr. Gurma, and thank you everyone for joining. I'll just briefly go over what we did last time, and then proceed to the aortic space. Last time we were trying to introduce the field of structural heart disease, and we said it is a spectrum of interventional procedures that are performed in the non-coronary space in the heart, okay, in the heart structure, excluding coronary artery interventions. Predominantly, what we talked about was, stroke prevention, recurrence of stroke in terms of closing patent foraminal valley, and also placing left atrial appendage closure device for those patients who have atrial fibrillation and who are not candidates for systemic anticoagulation due to bleeding problems. I showed you a case of mine who had atrial fibrillation, but who also had a GI bleed and coronary artery disease. So in that sense, closing the left atrial appendage with the Watchman device would be the way to go to simplify the patient's regimen in terms of anticoagulation. But we spent the vast majority of the time that we had last time on mitral valve. As you know, rheumatic mitral stenosis is the most common valvular heart disease in the world. Although we don't see it that often here in the US, me being trained in Ethiopia, I know how many of those cases you guys see on a daily basis. Therefore, we talked about the anatomy of the mitral valve and the valve structures. We said the mitral valve is one of the two major AV valves that sit between the left atrium and left ventricle. We also talked about the structure of the valve. It's a relatively complex valve compared to the other valves, particularly the semilunar valves. The annulus of the valve is what anchors the valve in position, and it's a very complex structure, particularly if you're thinking about putting a percutaneous valve in this position. The valve structure itself, the annulus, is not on the same plane. It's a saddle-shaped structure. So it is something to really understand the mechanism of disease processes. The leaflets, this is the anterior leaflet, this is the posterior leaflet, are basically the attachments to the annulus. And obviously the closure line, like I said, of those leaflets is called a commissure. And that is what is really affected with patients who have rheumatic mitral stenosis and valvulitis, and commissural fusion is one of the pathognomonic signs of a severe rheumatic mitral stenosis. At the tip of the leaflets, as you can see, there is an attachment of chordae tendineae, and that is subsequently attached to a structure called a papillary muscle. So any pathology that affects the ventricle can also affect the mitral valve. So if you have a mitral valve regurgitation from a ventricular problem, that is called secondary mitral regurgitation. It's actually the ventricular problem. Usually cardiomyopathy, non-ischemic cardiomyopathy can give you severe mitral regurgitation. If the pathology is only affecting the mitral valve apparatus, it's usually primary mitral valve pathology. It's usually primary mitral regurgitation. Those are fibroelastic deficiencies in this country. Also, mitral valve prolapse, and also, infective endocarditis can give you primary mitral valve regurgitation. Diagnosis, we say clinical exam and also echocardiography are the key in terms of diagnosing mitral valve problems. But in terms of therapy, we emphasized how important it is to actually prevent mitral valve pathologies. In terms of rheumatic heart disease, detecting the valve pathology is really key. Surveillance and also In terms of treatment, there is medical therapy that we can do. We can do diuretics and a beta blocker therapy to, decrease the heart rate. So these patients, they don't tolerate tachycardia because mitral stenosis is a diastolic problem, and therefore you have to slow those patients down. However, it's like I said, it's a mechanical problem, and the solution is usually has to be mechanical. And if you have a very severe mitral stenosis that is symptomatic, you have to either do surgery or you have to do percutaneous mitral balloon valvuloplasty. And the decision whether to go for surgery or to do percutaneous mitral valve valvuloplasty is dependent on the Wilkins score. That means the echo score, the structure of the valve, how calcified it is, and the presence of either, mitral regurgitation, concomitant mitral regurgitation. If you have moderate or more than mitral regurgitation concomitant with the mitral stenosis, it's really not advised to do balloon valvuloplasty, as you may run into severe mitral regurgitation. So that is kind of what it is for mitral. So if you have any questions, feel free to bring it up and we'll discuss. So the next major valve is the aortic valve. The aortic valve is a fairly simple structure, unlike the mitral valve, and it sits between the aorta and the left ventricle. As you know, this is systole simulated on the right and diastole simulated on the left. And it's a systolic opening valve, a high pressure opening valve, and it has three cusps. It's a tricuspid. The normal aortic valve is a tricuspid valve, and this thin unrestricted opening of the valve is what usually happens in normal aortic valve, which is 3 to 4 centimeters square in terms of area. And obviously the valve has the lower edge of the valve is where the annulus is. And these guys here, they're called sinuses. There's a left coronary sinus, a non-coronary sinus, a right coronary sinus. This is named based on which coronary artery actually arises from the sinuses. So the left coronary sinus is where the left main coronary artery originates. The right coronary sinus is where the right coronary artery originates. The sinus that doesn't have any coronary artery is called the non-coronary sinus. And the sites of junction from the sinus to the ascending aorta is called sinotubular junction. Those structures are very important if you're considering percutaneous valve intervention. The sinus depth, the sinus height, and all those things are going to be very, very key. So there are some congenital valve abnormalities that are worth mentioning. So the normal aortic valve, we said it's a tricuspid valve. But congenitally, about 0.02% of valves can be unicuspid. You can just have one cusp. Those patients are usually actually diagnosed early in life, and it could be the most common cause of fetal congenital aortic stenosis in kids. As you know, this could also be a bicuspid aortic valve or a quadricuspid aortic valve. So a bicuspid aortic valve is actually the most common valve abnormality, congenital valve abnormality, and usually associated with aortic stenosis. Unicuspid aortic valve is also associated with aortic stenosis, but quadricuspid aortic valve is usually associated with aortic regurgitation. The etiology of aortic stenosis, the vast majority of aortic stenosis in the developing world is again dramatic. But the most common cause of aortic stenosis in the Western world is calcific degeneration of a trileaflet aortic valve. The diagnosis is clinical. Also, echocardiography is very important. In terms of therapy, we will talk about that. So here on the right, if you see, this is a calcific degeneration of a trileaflet aortic valve. You can see a chunk of calcium here involving all the three cusps. But if you look at the commissures are not really fused. If you see this is a bicuspid valve. The bicuspid aortic valve pathologies are known for their chunky very big and heavy calcification and associated with severe aortic stenosis. If you look at here, rheumatic aortic stenosis, there is the same thing, the same pathology that happens with mitral stenosis is actually happening here as well. There is commissural fusion. This has some therapeutic implication because if you do balloon aortic valvuloplasty for the rheumatic mitral aortic stenosis, you can actually open this up and patients will do just fine. But we almost never do balloon aortic valvuloplasty for these guys here in this country because they're essentially trying to open up a rock. It is very, very heavy to crack it. Even if you crack it in about a week, patient comes back because of the recoil capacity of this lesion here. So these are some therapeutic implications. And the same thing here is calcific degeneration of aortic valve. You can do balloon aortic valvuloplasty for an emergency kind of salvage type of therapy. For those patients who present to the emergency room with acute decompensated heart failure, you can do it, but like I said, it's not a durable result. But we bring those patients back for the permanent therapy, which is a transcatheter valve therapy. Again, if you look at this, this is a rheumatic valve, and you get a nice reduction in gradient, and rheumatic balloon valvuloplasty is durable. As you guys know, aortic stenosis is a lethal disease. We don't talk about this often, but if patients have symptomatic severe aortic stenosis, really the mortality is worse than some of the cancers that we really fear about. So if you have a patient with severe aortic stenosis and they have heart failure, for example, their average survival is 2 years. And if they have syncope or angina, really the 5-year survival is very low. So it is a very lethal disease that needs to be addressed. If you compare it with some of the cancers that we really talked about, look at lung cancer, for example. The 5-year survival is metastatic lung cancer is 4 years. If you have severe inoperable aortic stenosis, your chance of dying surviving 5 years is like 3%. So it is really something that we need to pay attention to, and aortic stenosis, as you know, is one of the very undertreated valves. The etiology of aortic stenosis, we already kind of talked about this: rheumatic heart disease, globally, calcific degeneration of the aortic valve. In the Western world, bicuspid aortic valve, of course, radiation drugs, and also congenital diseases are some things that we need to kind of pay attention when we see aortic stenosis in younger patients. So what defines severe? Like I said, whenever you diagnose valvular heart disease, it's really diagnosis is not the end of the word, right? So you have to diagnose it and also stage the disease, where they are. Are they mild, moderate, or severe? Even if they're severe, do they have symptoms, is really the key to approach this patient. What defines severe aortic stenosis? Exam-wise, you guys do a lot of physical examination. So it's a late peaking crescendo systolic murmur is really with diminished P2, A2 is really, and the longer the duration of the murmur and the more muffled the P2 is, A2 is the more severe the aortic stenosis is. But of course, you can't make the full diagnosis without doing echocardiography, because your therapy, what you do for those patients, actually depends on their valve structure, how calcified the valves are, how fused the leaflets are, how big the sinuses are. Also, if they have concomitant dilated aortic root, what you do for those patients is really different. Otherwise, maximal transvalvular velocity greater than 4 meters per second, and mean gradient greater than 40, and aortic valve area less than 1 square centimeters, or if you index that valve area, if it's less than 0.6 centimeter square per meter square that will give you severe aortic stenosis. This is the kind of what the echo looks like, a CW Doppler across the aortic valve. Shows you this velocity about 4, which is, you know, essentially severe aortic stenosis. I just would like to say one thing about echo and aortic stenosis. It's very possible to underestimate the severity of aortic stenosis by echo, but you almost never, I say almost, because you may overestimate in very rare cases of very severe anemia or thyrotoxic or something like that. But the vast majority of patients, if you undergo echo and you have severe aortic stenosis, that is what they have. It's really never overestimate. However, whenever you evaluate patients with suspected severe aortic stenosis, the absence of high gradients does not mean they don't have severe aortic stenosis. It's all about the left ventricle pushing blood across the aortic valve, which generates the gradient, right? So if you don't have a good left ventricular function, if the ventricle is weak to generate that gradient, you may have severe aortic stenosis, but you may not generate that severe gradient. So in those patients who have severe left ventricular dysfunction and the valve area is still in the low range, which is less than 1, we can actually give them some dobutamine, okay, to increase their contractility and help them generate that severe aortic stenosis range of gradient. If the gradient goes up, but the valve area stays low, that means that is low flow, low gradient severe aortic stenosis. Sometimes patients can also have paradoxically low flow, low gradient, normal ejection fraction aortic stenosis. So this will tell you the spectrum of disease. So just the absence of high velocity and the absence of high gradient, if the patient is symptomatic, does not really exclude this disease. So this is something to really pay attention to. So in terms of management of severe aortic stenosis, obviously if you have a patient with severe aortic stenosis and they're symptomatic, you have to do something. What you do is either surgery or transcatheter aortic valve therapy. Right now in the US, of course, transcatheter aortic valve is FDA approved for the whole spectrum of risks, high risk, intermediate risk, or low risk recently. Of course, surgery is still class 1, and transcatheter valve therapy, depending for which risk of patients you're talking about. If you have a prohibitive risk, surgical risk, it's class 1. And also, if you have high surgical risk, either surgery or transcatheter aortic valve therapy can be performed. The low and intermediate risk, still depending on the patient's age, you may go for surgery than transcatheter therapy, which we'll talk about in a minute. So open heart surgery, works nicely, has been around for a long time, and it is a proven therapy, really. However, of course, open heart surgery, it does require general anesthesia. It does require heart-lung bypass machine, and also longer duration of hospitalization. Also, you have patients that have to go to rehab. All those things are the downsides of long surgical therapy. How about percutaneous aortic valve replacement? Okay, when it was told initially in the early 1990s, people thought it was a crazy idea to percutaneously actually place a valve in the aortic position without doing any sort of sternotomy. And most of the challenges that they were thinking about was this is a very calcified valve, and how can you even access it? If you put a valve, the valve may collapse. The radial strength was not good. And they also thought about the coronaries. If you dilate these valves with a catheter, you may close the coronary arteries, which arise right at the cusp, and that may be a disaster. But in 1994, as you guys may know, Alain Cribier performed the first post-mortem kind of study to place a valve, which is a stent essentially in a cadaver to see if actually the valve holds enough radial strength to keep this calcific degenerated valve open, and it did. And this was repeated in 2002 in Washington, D.C. And this was actually the first proof of concept that it is probably possible to keep this valve open with a stent strap. And 8 years later, in 2002, a patient comes back with cardiogenic shock on pressors, 57-year-old patient, in multiple medical problems with really prohibitive surgical risk. This patient also had lung cancer, and really they didn't have anything to offer this patient. Okay, this was in France. They performed echo. His EF was very low. He also, to complicate the matter, he had bicuspid aortic valve. His mean gradient was 30, but of course he has low EF. Like I said, he could not generate any gradient. He didn't have any good access. Also, he had aortobicameral bypass in the past and acute limb ischemia. It's really as sick as you can get. So the first in-man transcatheter aortic valve therapy was actually performed in that patient by Dr. Alain Cribier in 2002. And this is actually that patient a few hours after the procedure was performed. Dr. Cribier performed his first transcatheter therapy actually through the femoral vein. He went through the femoral vein to the right atrium, transeptal puncture through the mitral valve, through the LV, and deployed the valve like this through a rail, which is very, very cumbersome way of doing this procedure, but he didn't have any other option because the patient was really a vascular path. And this patient did fine, really. He died of something else down the road, but he did very well. This was essentially a revolution in the transcatheter therapy for aortic valve. So the story of transcatheter aortic valve therapy, as you can see, the first in-man balloon aortic valvuloplasty was performed by this same person, Alain Cribier, in 1985. In 1994, as we just went over, a post-mortem study in 1999, in 2000 animal implantation in ships. The first in-man transcatheter heart valve was implanted in 2002. In 2002-2003 was a very exciting time. All the companies were taking on this valve therapy, and in 2007, it was actually, the valve was CE marked in Europe for commercialization. And in 2008, 2010, Edwards and Medtronic, they started, looking into this valve, and the valve was FDA approved in the US in about 2011. So this is, one of the very few stories in cardiovascular medicine that have shown significant mortality benefit and rapid evolution of this therapy. Right now, as you guys know, transcatheter aortic valve therapy is a very, very mature procedure in this country. We have 3 valves here in the US. The first valve is Edwards valve. There was the Sapien XT valve, which is a bovine pericardial valve, and the cobalt and chromium alloy for its frame. This is the latest generation of the valve, which has actually a sealing skirt. Paravalvular regurgitation has been a problem with this valve, and they put another skirt on it to minimize the risk of paravalvular regurgitation after the valve was implanted. And this is the most commonly used valve, and we have a lot of experience with this valve. The second valve is the Evolute Valve, which is a Medtronic valve. It's a porcine pericardial valve in stainless steel. It's a self-expanding valve. You actually just deploy this valve and it expands by itself due to the temperature change of the body temperature, and it just seals itself. We don't have, these are still in clinical trials. The Accurate Neo Portico are still in clinical trials, but we don't have experience with these three valves. The third and the latest addition of valve into the US market is the Lotus Valve, which is a mechanically expanding valve. It's not a balloon expander, it's not self-expanding, but it's mechanically expandable tissue valve. This is how TAVR is performed today. Transfemoral access, a wire in the left ventricle, balloon aortic valvuloplasty, essentially pace the heart at 180 beats per minute, balloon it, come out. It's about 1 hour procedure, skin to skin, and they go back with the valve. If the valve is crimped on this catheter, this is the valve right here, it's crimped, but the balloon is here, so we load the valve on the balloon, pull it back a little bit. This is called the commander delivery system. The valve goes in. A little bit of maneuvering to not to scrape the aortic wall. That's the risk of stroke here. And the valve will be positioned, and the pusher will be pulled back, this pusher, and will pace the heart again at about 180 beats per minute. You position the valve based on fine adjustment, pacing, valve deployed, stop pacing, delivery system comes out. We do some measurements, with pigtail catheter, gradient results, and essentially the femoral artery will be closed with ProGlide device or PerClose. So that is obviously animated. This is what it looks like in real life. This is after the valve is deployed. We'll do supravalvular aortography to check for aortic regurgitation. So access has been really an issue for some of the patients. Transfemoral access is really the preferred access in this group of patients because it is associated with early discharge, very low risk of complications. However, as you can imagine, some patients don't have good transfemoral access, and they do have severe peripheral artery disease. For those patients, an alternative access has been developed. Transapical and transaortic has been the most commonly used alternative accesses early in the evolution of this valve therapy. But nowadays we also do have other alternative accesses that are transcarotid, perc axillary, transsubclavian, also a transcaval access where you go from the inferior vena cava puncture into the aorta and essentially deploy the valve. And when you come out, you close the aorta, which is a relatively new procedure. So there is really explosive growth of TAVR globally. And as you can see, there is an exponential growth of transcatheter aortic valve replacement in the world. That is essentially because the valve therapy, this valve therapy is actually evidence-based. In the valve trials are arguably one of the most nicely done clinical trials, and there is a lot of evidence that actually the valve hemodynamics may even be better than surgical valves in terms of, in reducing gradients and getting good valve area for this group of patients. Familiarity with the procedure is expanding really fast. The technology is improving really by the day. As you can see, the first generation valves were already replaced by the second or third generation valves. And then outcomes, our real world outcomes are very, very good. So what is the basis for all this? If you think about severe aortic stenosis, inoperable, if you cannot undergo surgery, what is your option? Essentially nothing. What is the medical therapy for severe aortic stenosis? Nothing. There is no medical therapy that will fix severe aortic stenosis. If you have a patient with severe aortic stenosis, they have heart failure, you may give them some diuretics and help them here and there, but really there is no medical therapy. So the partner 1B cohort was the first trial that actually randomized these patients who are prohibitive risk, they cannot undergo surgery, to a valve therapy versus medical therapy, which is valve therapy versus nothing. Maybe some had underwent valvuloplasty, but like I said, balloon aortic valvuloplasty is not a durable therapy. So they saw a huge survival in terms of for those group of patients who underwent valve therapy. But this was, in 2009, 2010. And then they went down the risk spectrum and looked at patients who are high surgical risk. They can undergo surgery, but they have the surgical mortality is about 8%, greater than 8%. So they compare those patients, and TAVR did just as good for those patients who are high risk. And they continue to go down the risk spectrum, and PARTNER 2A and SURTAVI trials, the two major trials that looked at those patients who are intermediate risk. Their surgical mortality is 3 to 8% if they undergo surgery. But how about valve therapy? And the comparison for those two patients is actually just as good. TAVR turned out to be just as good with, of course, with early discharge and less risk of complications related to the surgery. And then recently, as you guys know, the PARTNER 3 trial actually compared low risk patients. These patients, even if they undergo surgery, their mortality is less than 3%. So they compared those low risk patients for surgery versus TAVR. And as you might imagine, TAVR came out just as good. So FDA approved TAVR for the whole spectrum of risk, from low risk to high risk to intermediate risk to prohibitive risk, very recently, in August 2019. Now, essentially, as you might imagine, most of aortic stenosis is down here. Most of the surgery for severe aortic stenosis is performed for low risk patients, not too high risk. So this is a big group of patients that will be undergoing transcatheter valve therapy. Of course, that is all the positive side of valve therapy, transcatheter valve. What are the challenges, really? Whenever you put a transcatheter valve, as you might imagine, depending on which type of valve, you do cover in the coronary arteries. There is if you're putting transcatheter aortic valve in a 50-year-old patient, the chances of those patients coming back with acute coronary syndrome and needing some kind of coronary work is relatively high, because and then they come back, you may not have a good access to the coronary arteries. So this is one thing to think about before you subject these patients to transcatheter valve. Could they need coronary intervention down the road? Particularly if you put the Medtronic valve, the skirts are very tall. They actually cover the entire coronary, that's up to the STJ. So it is something to really think about. So who gets SAVR? You know, right now the question is not the question is not really who gets transcatheter aortic valve, but the question is who gets surgical valve, really. Of course, TAVR has expanded, but we shouldn't offer transcatheter aortic valve to everybody. Anatomy is really important. You know, do they have high risk anatomy? Okay, do they have good sinus depth? Do they have low coronary height? If the coronary heights are low, the chance of coronary obstruction is very high. If they have LVOT calcification, do they have big chunk of calcium sitting in the left ventricular outflow tract, in which case when you deploy the valve, particularly a transcatheter balloon expandable valve, it may actually disrupt that valve. They may have annular rupture, which is a very, very bad complication that patients may not survive. Do they have bicuspid aortic valve? Because as I showed you earlier, the calcium burden is very bulky with bicuspid for some reason. So if they have very bulky calcification, again, the chance of closing the coronary arteries is high. And also the valve, when you deploy it in a tricuspid valve versus when you deploy it in a bicuspid valve, it doesn't conform nicely. So there is a risk of paravalvular regurgitation. When you have paravalvular regurgitation, think about it. These patients, they've been having severe aortic stenosis for so many years. Now their LV is really small. They have concentric hypertrophy. So even quite a little bit of aortic regurgitation, they cannot tolerate that. So mild, moderate, and severe paravalvular regurgitation, they've been all associated with high risk of poor outcome. So you have to, consider all these things before you offer a patient transcatheter valve therapy. Also, do they have any other, lesion that would require surgery? Do they have mitral regurgitation? They can undergo open heart surgery and fix both at the same time. Do they have severe coronary disease that would require bypass surgery? In that case, they can undergo open heart surgery. They can undergo CABG and AVR both at the same time. Okay, so that was aortic stenosis. So aortic regurgitation is the next thing I would like to touch upon. And I actually saw this patient last week on Tuesday. So I'm just going to present to you and see what you do for them. Okay, this is a gentleman, the 72-year-old, history of bypass surgery ×2 and aortic valve replacement about 13 years ago. Now he presents with, progressive shortness of breath and pulmonary edema, cardiogenic shock. He has sinus tachycardia in the low hundreds. And you diagnose this patient with aortic regurgitation. Okay? So he does have acute aortic regurgitation. I guess the question is, which of the following therapies are contraindicated? Which of this you will not do for this patient? It could be more than one answer, but I just wanted to see what the audience would do. Would you give
let's give 30 seconds for people to give answers. So A, beta blocker, B, nitroprusside, C, diuretics, and D is a balloon pump. So you're asking, which one would you not do?
Yes. acute severe aortic regurgitation.
So we have an answer A and D. There is an answer of A. There is also B. So far you have A, B, and D. Nobody is, again, is C. Oh, there's also C. So I think the audience is definitely there's more A. You don't want to beta block. Well, there is a D, which is unless this case is refractory. So, okay, I think you got some answers. You got everything.
All right. Okay, so this is a patient who has acute aortic regurgitation, right? And he had a valve in the past. This is a bioprosthetic valve dysfunction. And he got this valve for severe aortic stenosis. That would tell you the patient did have some degree of, left ventricular concentric remodeling in the past. And now he comes in and with severe aortic regurgitation. Really what I'm trying to drive home here is they are tachycardic for a reason. So if this patient is tachycardic, that is essentially what maintains their blood pressure. Okay, so do not slow them down. They have severe aortic regurgitation. Until you actually give them some sort of therapy, slowing that patient down, is mainly compromising their cardiac output. So beta blocker therapy is not a good choice. Of course, balloon pump, as you know, is one of the circulatory support devices that we use for severe mitral regurgitation because it reduces afterload and it deflates in systole and it inflates in diastole to improve coronary perfusion pressure. But in this case, if you think about it, in diastole, actually the aortic valve is wide open, okay? Now, if you inflate the balloon pump, you are actually compromising the patient's blood flow to the coronaries and making the situation worse. So in a severe, acute, or whatever aortic regurgitation, balloon pump is contraindicated. And beta blocker therapy is not the first choice. Of course, they may have severe peripheral vascular resistance. In that case, if they have some blood pressure, you can give them nitroprusside, which is a vasodilator therapy. So that will kind of reduce the peripheral vascular resistance, and the heart can pump a little bit better, and blood flow to the vital organs will improve. Diuretic therapy, of course, he is in pulmonary edema. That would be something that you'd like to do. This patient was actually tested. They thought it was COVID when he presented to the emergency room because he has acute hypoxic respiratory failure, bilateral pulmonary infiltrate, suspected for COVID, tested negative. They tested him again, and he tested negative, and that's actually when we were involved in his care. We did echo. This is a transthoracic transesophageal echocardiography. As you can see, there is a color Doppler, which this is the aortic valve, and you can see the color going down here, which will show you there is aortic regurgitation. So not just the regurgitation, as I was saying, you probably know this patient already has aortic regurgitation just by the story and the physical exam, but you cannot tell actually what's going on until you do echocardiography. You can see here something moving up and down. So there is a problem with this aortic bioprosthetic valve. This thing that is prolapsing in and out is a prosthetic valve dysfunction, which is prolapsing. And you can see it with 3D here, moving up and down, the same thing. So now you know why the patient is having aortic regurgitation, and now you know what to do for that patient. That means you know the mechanism of aortic regurgitation in this case. Because when somebody has aortic regurgitation, I'll talk about it in a minute, it could be a valve-related pathology. It could be the valve itself. It could also be the aortic root, okay? The aortic root continues to dilate. The annulus of the aortic valve can dilate and patient can have aortic regurgitation. But this is not what's going on here. So what did we do? This patient, of course, surgery, right? So, but however, he's evaluated by surgeons and they say he's too high risk, that he may not survive the surgery. Now he has a prosthetic valve at the aortic position, which is dysfunctional. So this patient has really no choice either. You know, he's in shock, right? So we needed to do something for this guy. So we, did right heart cath and, medical therapy. He was in the unit for one day, and next day things are not going in the right direction. So we took him to the lab, and then we placed a 23 millimeter S3 valve in his aortic position, as you can see here. And he did great. Okay, so he is still in the unit today, but he is really recovering nicely. So in the past, a patient like this, if he's not the surgical candidate, really there is no other option. He would die. But nowadays, you can put a transcatheter valve in his old valve. You can put a new valve, and his diastolic pressure, in front of our eyes, went from 30 millimeters of mercury to 70 millimeters of mercury right away. He went to complete heart block right after the procedure, but subsequently recovered. As you might imagine, when you deploy this valve, you may actually compress on the bundle, left bundle, and patients can go into complete heart block. This is what I was trying to say. You really have to understand the anatomy of the aortic root, because this interaction, the interplay between the different components of the aortic root is what would allow you to be able to treat these patients with transcatheter therapy. So LVOT here, the annulus, the valve leaflet, the cusp, the sinuses, okay? And the coronary height. From here to here is how tall the corner, how high the coronaries are, that for you to assess. The sinotubular junction. So whenever somebody has severe aortic regurgitation, it could be the valve, it could be the aortic root. Dr. Girma was talking about aortic type A, aortic dissection. So a patient can have aortic dissection where the flap actually goes down here and cause severe aortic regurgitation. So those patients will come to you with pulmonary edema, but it's really the valve is fine. It's a dissected aortic root that is causing all this severe aortic regurgitation. So when you talk about aortic regurgitation, it's important to differentiate if it is severe acute versus chronic. Chronic is one of the most tolerated valve lesions because it happens over time, and over time the left ventricle continues to dilate. It will accommodate the volume that comes back. Whereas acute aortic regurgitation, the ventricle is unprepared, and all this blood comes right back to the ventricle, goes to the left atrium. Sometimes patients can have diastolic mitral regurgitation, believe it or not, and they have severe pulmonary edema. It's a very, very bad situation. So it is something that you need to think about. So what are the causes of aortic regurgitation? It could be endocarditis. Okay, this patient I just showed you luckily did not have endocarditis, but if it is endocarditis, even it's a bigger challenge because you put a prosthetic valve and now the valve will be infected, so it's going to be challenging. Of course, aortic dissection is something we need to think about, and syphilis, as Dr. Mendoza was mentioning about the syphilitic aneurysm last session. syphilis is essentially vasculitis. So that vasculitis affects the vasa vasorum of the ascending aorta, and that ascending aorta continues to dilate. So that can cause aortic dissection, which is rare to present with acute aortic regurgitation, but these are most of the time with chronic aortic regurgitation with all those signs of severe AI. This we kind of said it already. So there are different, very interesting peripheral signs of chronic severe aortic regurgitation. I have seen this in Ethiopia when I was a medical student, but you almost never see them here because patients are intervened early. The water hammer pulse, you almost never see them because for this to develop, the patient has to have severe aortic regurgitation for a really, really long time. They are all, interesting and very, very high yield for exams, but really we don't have to see this. We should intervene on these patients before they develop all this peripheral stigmata of severe aortic regurgitation. In terms of echo criteria for diagnosis, of course, you need a separate session to discuss echocardiography for different valve lesions, but these are kind of the guidance that we follow. Aortic root pathology is something that you really need to assess, because if you have aortic regurgitation and if you have big dilated aortic ascending aorta, that could be the culprit. That may be all you need to do. You have to replace the root. Sometimes you have to also replace the valve, which is a Bentall operation. But if it is the valve is spareable, it's better to spare the valve if you can. And of course, the coronaries needs to be reimplanted as well. So is it the valve, is it the root, or is it both? Okay. So this is just to show you how bad sudden severe acute regurgitation is. This left ventricle is prepared for a certain amount of end-diastolic volume. But when you have acute severe AI, this unprepared ventricle is actually flooded with this volume, and patients are terrible. This patient ended up on the ventilator in the emergency room. Although people thought it was COVID, but it wasn't. So in summary of structural heart disease interventions, it is, it could be valves, which is the most commonly intervened structure in the structural world. Any of the valves can be intervened. And it could be septal defects, ASDs, PFOs, CSDs. It could be fistulas, the coronary fistulas, the pulmonary, coronary to pulmonary fistulas, coronary cameral fistulas. And also could be obstructions, coarcts, and other obstructions. And also atrial appendage closures, ventricular assist devices, and septal ablations, all in the spectrum of structural intervention. So if you look at the summary for the valve, right now, aortic stenosis, who gets transcatheter valve? Essentially everyone, except for few patients that would need to undergo surgery. Aortic regurgitation, unfortunately, we don't have a dedicated valve for aortic regurgitation. The reason being, the reason why we can put aortic valve for aortic stenosis is there is a lot of calcium, bulky calcification, so the calcium can anchor the valve. But with aortic regurgitation, you don't have a lot of calcifications. But if you put the valve may embolize. So there's a new valve called the Yena valve that is being tested right now. But right now, we don't have a dedicated valve, so we use it off-label. For mitral regurgitation, functional MR, everyone can undergo mitral clip. I know I didn't talk about mitral clip. But if it is degenerative mitral regurgitation, surgery is still gold standard. Mitral stenosis, rheumatic mitral stenosis, everyone can undergo balloon mitral valvuloplasty if the anatomy is favorable, if the Wilkins score is less than 8. Of course, there is there are trials going on for tricuspid for valve-in-valve therapy. So in a nutshell, the structural heart disease is an evolving, rapidly evolving field of cardiovascular medicine, and it's not just you. This is a teamwork. You need a cardiologist, you need a vascular surgeon, you need, imagers, heart failure doctors, anesthesiologists. So it's kind of a team approach. So no procedure is done just by one person. We have the surgeon at the table who is helping. So for this, the patient is actually in the center of this care. So it is very exciting time. So this is kind of the end of my slide, and thank you very much for your time. And you stay safe. Don't forget to use mask. If you have any questions, please let me know. This is my email. I also do post some of these procedures on Twitter. So feel free to join there. And if you have any questions, I'm happy to answer. Thank you very much.
Thank you, Dr. Tesfaye. I think today I'm leaving a little bit more smarter after all this cardiology series. Has been outstanding lectures over the past 2 weeks. And I'm also glad to see that the interventional cardiologists have not taken away everything from the surgeons. The surgeons still have some work to do.
Yeah.
I think the future is written on the wall. I think surgeons, particularly in the cardiovascular surgery area, have to definitely be open and participate and accommodate what's coming through the technological advances. That's what vascular surgery has done, and I think our cardiac surgery colleagues maybe needs to come down from the moon and start working the cath lab with you guys. So with that, just before I take some questions, that's why I was looking at the Medtronic valve that you showed, how it has almost a supravalvular attachment kind of thing. That's how I would put the analogy, because we have with the aortic stents what we call a suprarenal stents. And I was wondering if that had a different way of deployment. Can you catheterize or partially first deploy, catheterize the coronaries, and then deploy the valve? How does it work? Because when you have something that extends above the coronary origin, it might be very risky. Can you just go over the technicalities of that, and then maybe we'll take some questions?
Yeah, that's a very, very good question. So there is a valve frame and there is a valve skirt. So the skirt is actually the tissue that is below the coronary height. Okay, the valve frame goes above the coronary height, but that has a diamond-shaped hole in it. So the blood flow, as you know, the coronaries fill in diastole, and the valve leaflet actually closes in diastole. So that will give some, space for the coronaries to fill. Otherwise, you said it absolutely right. That valve is actually called a supraannular valve, and it does scare you when you deploy it. It feels like it is covering the coronary arteries, but in reality, it does not.
Good. So
there is low coronary height.
Okay, perfect. So there is one question that was given here. When do you think is the best time to do valvuloplasty or TAVR in patients with aortic stenosis, bicuspid aortic valve stenosis, and in case of congenital aortic stenosis? I think the question probably is like, when would you just do only balloon, and when would you do TAVR? If I can maybe paraphrase the question, that might be how the question is. Probably, do you stage these things? I mean, before TAVR, probably you did, but now do you?
No, actually, unless the patient is presenting to the emergency room with heart failure symptoms, we almost never do isolated balloon aortic valvuloplasty for a calcific degeneration of aortic stenosis. But for the Ethiopian setting, this is different, because If there's aortic stenosis, most likely that is rheumatic. So if they don't have concomitant regurgitant lesion, it is actually good to do balloon aortic valvuloplasty because that is durable. It's just you split the commissures. But here, really, if you do valvuloplasty today, 2 weeks later, the gradient is the same because it's recoiling. It recoils. It's very calcific disease process, completely different. So you don't have to do isolated balloon aortic valvuloplasty unless the patient is presenting with acute decompensated heart failure, like a bridging BAV, we call it. We bridge it to TAVR.
Okay, one more question is, which antihypertensive would you use if you need to use antihypertensive in this patient, in patients with severe aortic stenosis?
Yeah, high blood pressure is usually not, an issue here. But what I would say is be careful with vasodilator therapy because these patients are extremely preload dependent, okay? Now, if you give them vasodilator therapy, now their preload will be compromised and they're afterload sensitive. So it is kind of tricky. So I would say avoid vasodilator therapy, but in terms of treating hypertension, you can really use anything. Beta blockers probably would be my go-to because if you, unlike the AI patients, the aortic stenosis patients, you can give them some time to heal.
Great. Dr. Enoch, I see you there. And Dr. Wondosen first, you have some comments, Wondosen?
No comment, but it was an interesting lecture, easy to follow. We used to classify aortic stenosis, I don't know if that is the case now, as valvular and subvalvular.
Yeah.
Do you still hold that? And the other question I have is syncopes, Stoke-Adams syncopes as a symptom, We used to teach this, yeah.
Yeah, absolutely. Yeah, thank you for that question, Dr. Wondosen. Yeah, particularly in the pediatric population, aortic stenosis actually is classified as subvalvular, valvular, and supravalvular aortic stenosis. So there is a subaortic membrane that actually manifests as aortic stenosis. Sometimes we see it even in older patients. It was somehow missed during their pediatric evaluation, and they present with aortic stenosis symptoms. But that is really the valve opens nicely on echo, and you don't understand what you see the gradient, but the valve opens nicely, and then usually we do MRI for those patients, and you find subvalvular membrane, or you can find supravalvular membrane. And for the subvalvular membrane, they also have associated aortic regurgitation because the turbulence of the supravalvular membrane causes chronic trauma to the valvular plate, and they may present with aortic regurgitation. Yes, syncope is one of the three major presenting symptoms of severe aortic stenosis, and that is a bad sign. We had a patient just the other day who had syncope, broke their hip. We were asked to evaluate them for a pre-op evaluation. And when we listened, of course, severe aortic stenosis, ortho wants to take him to the lab, and he syncopized. This is a very tricky situation. So he cannot tolerate really general anesthesia. So we had to do balloon valvuloplasty and prepped him for the surgery. He undergoes surgery, and after the surgery, he will be evaluated for transcatheter valve therapy. But yeah, those are very